Nursing care of patients with coronary heart disease. Diagnostic test. An ECG takes a picture of electrical signals creating the heart rhythms. Echocardiogram is a videotaped image of heart structures that shows the chambers, valves, and movements. Holter monitoring detects irregular heart rhythms. Patients would wear a Walkman-sized recording box attached to their chest and probably wear this for about 24 to 48 hours. The patient should keep a diary describing what their activities are in order to correlate any rhythm disturbances with patient activities. Patients are taught that they should not take a shower or bath during the monitoring and continue with usual daily activities. The recorder then will store the information about the rhythm until the end of the testing, and then it is removed and data is analyzed. Event recorder is a patient would carry a pager-sized event recording box so they can make 1 to 2 minute recordings of their heart rhythm when they actually experience symptoms. So this is helpful for patients who have infrequent or very brief symptoms. Tilt table test evaluates potential reasons for fainting or syncope. A heart rhythm and blood pressure are carefully monitored while a patient rests on a special table. The table will tilt the patient upright at about a 70 to 80 degree angle for about 30 to 45 minutes. If the patient faints, it usually means that they have a condition called vasovagal or neurocardiogenic fainting. Electrophysiology study. This looks at the heart's electrical conduction system. The electrical impulses are applied to the heart to provoke and analyze a fast heart rate. This can diagnose symptomatic and potentially life-threatening slow and fast heart rates. Radionuclide ventriculography. This is also known as a multiple gated acquisition scanning, a MUGA scan, and it's a nuclear medicine test that measures the heart's pumping ability. Cardiac catheterization is when a catheter is threaded to the heart, and it obtains tissue samples of heart muscle that may be damaged or measure the pressure in the heart or diagnose blood vessels or heart valve disease. The catheter is inserted under X-ray guidance. A thallium scan is a radionuclear study that determines viability of myocardial tissue, necrotic or scar tissue that does not extract the thallium isotope. Monitoring of the mitral and aortic valves and visualizing the ventricular systole and diastole is information available from the cardiac catheterization with the angiography. Defibrillators are also known as automatic external defibrillators or AID, which are the small portable defibrillators. Ventricular tachycardia and ventricular fibrillation that cause loss of consciousness must be immediately defibrillated. To ensure a safe defibrillation, there must be an announcement they are about to shock. I'm clear, you're clear, we're all clear. Because electricity is carried along metal devices and the patient, all personnel, including the one administering the shock, must stand back from the bed. The person defibrillating the patient is ultimately responsible for everyone's safety. Single chamber pacemakers, there's only one wire, a pacing lead, placed in the chamber of the heart. Sometimes it is the atrium, other times it is the ventricle. A demand pacemaker spikes varies with the heart rate. An atrial pacer would produce a spike, normally with a P wave. Dual chamber pacemakers. Wires are placed in two chambers of the heart. One lead would pace the atrium, the other the ventricle. This approach closely matches the natural pacing of the heart. This type of pacemaker can coordinate function between the atrium and ventricle. A dual chamber pacemaker normally produces two pacing spikes, one before the P wave and one before the QRS. Rate responsive pacemakers have sensors that automatically adjust to changes in a person's physical activity. Other devices like an implantable cardioverter defibrillator are designed primarily for other functions and can function as a pacemaker in certain situations. Cardiac ablation uses radiofrequency energy. This puts an end to arrhythmias that originated at that site. Candidates for this procedure have abnormal heart rhythms that cannot be controlled with lifestyle changes or medication. Most often, cardiac ablation is used to treat heartbeats that begin in the atria. Ablation usually isn't your first treatment option, and it's an option for those who have tried medication to treat an arrhythmia without success, have certain types of arrhythmias that respond well to ablation, like Wolff-Parkinson-White syndrome, or have a high risk of complications from their arrhythmia, such as sudden cardiac arrest. Cardiac ablation does carry risks, which is bleeding at the site where the catheter was inserted, damage to blood vessels where the catheter may have scraped as it traveled to the heart, puncture of the heart, and damage to the heart's electrical system, which could actually worsen the arrhythmia. Blood clots would also be a risk factor. The patient will need to stop eating and drinking about 8 to 12 hours before the procedure. Cardiac resynchronization therapy uses a specialized pacemaker to coordinate the action of the right and left ventricles in patients with heart failure. It is mainly for a prolonged QRS. The wires that carry the electrical signals connect to an electrical pulse generator placed under the skin in the upper chest. Two leads which go to the right atrium and the right ventricle, and the CRT device has a third lead that is positioned in a vein on the surface of the left ventricle. This allows the device to simultaneously stimulate the left and right ventricles and restore a coordinated or a synchronous squeezing pattern. This is sometimes referred to as biventricular pacing because both ventricles are electrically stimulated, or you could say electrically paced, at the same time. This reduces the electrical delay and results in a more coordinated and effective heartbeat. Chemical cardioversion uses antiarrhythmic medications to restore the heart's normal condition. Electrical cardioversion is a procedure using electrical shock delivered through the chest wall to the heart to disrupt the abnormal electrical circuit and restore a normal heartbeat. The shock causes all of the heart cells to contract simultaneously and interrupt the abnormal electrical rhythm without damaging the heart. This split-second interruption of the abnormal beat allows the heart's electrical system to regain control and restore a normal heartbeat. Nursing responsibilities after cardioversion including airway maintenance, breathing and circulation, monitoring for dysrhythmias, and level of consciousness. Sudden cardiac death, and it is not the same as a heart attack because an MI can come gradually. Chest pain, arm numbness, tingling due to blockage of blood vessels, which slows or stops the blood flow. With sudden cardiac death, the heart suddenly stops working. Treating someone in sudden cardiac death requires the paddles to shock the heart, and this can happen when the heart's electrical system malfunctions. If the person does not receive cardiopulmonary resuscitation and defibrillation quickly, they will die. Cardiac treatments. Implantable cardioverter defibrillator detects ventricular tachycardia or fibrillation, and it shocks the heart to restore the normal rhythm. An implantable cardioverter defibrillator have been very useful in preventing sudden death in patients with known sustained ventricular tachycardia or fibrillation. Coronary angioplasty, also known as percutaneous coronary intervention, is done by threading a catheter through a small puncture in the leg or arm artery to the heart and opens a clogged heart artery by inflating a tiny balloon in it. Afterwards, the patient is at risk for bleeding from the arterial access site, so as a nurse, you should assess the patient immediately. Coronary bypass surgery. In a nutshell, it uses blood vessels from the chest or leg. One end is attached to the aorta, and the other end is attached to the coronary artery below the point where it is clogged, and blood can flow through the new channel to the heart. Corrective heart surgery. If a patient has a congenital heart deformity, a faulty valve, or diseased heart muscle due to cardiomyopathy, surgery to correct the abnormality may improve the heart rate and blood flow, reducing the risk of fatal arrhythmias. Heart transplantation is surgery to remove a damaged or diseased heart and replace it with a healthy donor heart. Cardiomyopathies are the diseases that weaken and enlarge the heart muscle. There are three types. Dilated cardiomyopathy is the most common type. The left ventricle becomes enlarged, dilated, and its pumping ability becomes less forceful, and blood does not flow as easily through the heart. Although this type can affect people of all ages, it occurs most often in middle-aged people and is more likely to affect men. The second one, hypertrophic cardiomyopathy, is an abnormal growth or thickening of the heart muscle. As thickening occurs, the heart tends to stiffen and the size of the pumping chamber may shrink, interfering with the heart's ability to deliver blood to the body. Restrictive cardiomyopathy. The heart muscle in people with restrictive cardiomyopathy becomes rigid and less elastic, meaning the heart cannot properly expand and fill with blood between heartbeats. Ventricular assist device. This is an implantable mechanical pump that helps pump blood from the ventricle to the rest of the body. They are used in people who have weakened hearts or heart failure. They may have the ventricular assist device implanted while waiting for a heart transplant or for the heart to become strong enough to effectively pump blood on its own. It may be implanted as a long-term treatment if they have heart failure and are not a good candidate for a heart transplant. If a patient develops right heart failure, medications may help improve the pumping ability of the right ventricle. A right ventricular assist device might be implanted to support the right ventricle. And to some degree, there is exertional dyspnea occurs in all patients. So as a nurse, you should really get a description of the degree of the exertion that results in them having that sensation of breathlessness. The left ventricular assist device helps support a dangerously impaired heart while the patient is waiting for a donor heart by extracting blood from the left ventricle and literally propelling it into systemic circulation. The risk factors: blood clots. Because as the blood moves through, say, an LVAD, blood clots can form and can slow or block normal blood flow through the heart, which could then lead to a stroke or heart attack, or could cause the ventricular assist device to stop working. They will need to be on aspirin or warfarin to help prevent blood clots after the ventricular assist device is implanted. Bleeding. Implanting it requires open heart surgery, and having open heart surgery can increase the risk of bleeding after the operation, especially if they're taking blood-thinning medications. Infection. Because the power source and control unit for a ventricular assist device is outside the body and connected through a port in the skin, there's an increased risk of bacteria getting in the port and causing a serious infection. So it's important that you would do teaching to watch for the signs of infection, such as soreness or redness near the port, fluid draining from the site, or a fever. Device malfunction. It is possible that the device could stop working properly after it's implanted. The pumping action of the device might not work exactly right, making it not enough blood that would pump through the heart. The power supply to the device could also fail, and other parts of the device may stop working properly. Right heart failure. The left ventricular assist device pumps more blood from the left ventricle of the heart than what the heart might have been used to before the LVAD was implanted. The right ventricle may then be too weak to pump the increased amount of blood. If a patient has severe cardiomyopathies and medications cannot control the symptoms, a heart transplant may be an option, and they're performed when other treatments for heart problems have not worked, leading to heart failure. Cardiac transplantation is now a standard effective treatment for patients with end-stage cardiac disease. Although receiving a donor heart can save a life, having a heart transplant has many risks. The most significant risk is the body rejecting the donor heart. The immune system may see the donor heart as foreign and will try to attack it. Although people receive heart transplant receive immunosuppressants to suppress the activity of the immune system, nearly 25% of heart transplant recipients still have some signs of rejection during the first year after transplant. Because rejection is most likely to occur in the early weeks and months after heart transplant, the frequency of heart biopsies is greatest during this period. It is possible for the patient to have symptoms of rejecting the donor heart. These symptoms would include shortness of breath, fever, weight gain due to water retention, not urinating as much as usual, fatigue. Other risks following a heart transplant include the walls of the arteries could thicken and harden, leading to cardiac allograft vasculopathy, and this can make blood circulation through the heart difficult and can cause a heart attack, heart failure, heart arrhythmias, or sudden cardiac death. Medication side effects: the immunosuppressants will need to take for the rest of their life, and it could cause kidney damage and increase their blood sugar. Cancer. Immunosuppressants can also increase a cancer risk. Taking these medications puts a person at greater risk of skin and lip tumors and non-Hodgkin's lymphoma. Infection. Immunosuppressants decrease the body's ability to fight infection, and many people who have heart transplant have an infection that requires them to be admitted to the hospital the first year after their transplant. Pulmonary edema. If pulmonary edema continues, it can raise pressure in the pulmonary artery, and eventually the right ventricle begins to fail. The right ventricle has a much thinner wall of muscle than does the left, and the increased pressure backs up into the right atrium and into the various parts of the body, where it will cause leg swelling, abdominal ascites, pleural effusion, congestion, and swelling of the liver. Treatment for pulmonary edema varies depending on the cause, but generally would include supplemental oxygen and diuretic. Pericarditis. Under normal circumstances, the pericardial sac that surrounds the heart contains a small amount of lubricating fluid. In pericarditis, this sac becomes inflamed, and the resulting friction from the inflamed sac leads to chest pain. In some cases, the amount of fluid contained in the pericardial sac may increase, causing a pericardial infusion. The most characteristic subjective clinical symptom of pericarditis is chest pain, and sitting up often relieves the pain. Pericarditis can also develop shortly after a major MI due to the irritation of the underlying damaged heart muscle. In addition, a delayed form of pericarditis can occur weeks after an MI or heart surgery because of antibody formation. This delayed pericarditis is known as Dressler's syndrome. Dressler's syndrome is due to an autoimmune response, and it's a mistaken inflammatory response by the body to its own tissue, and in this case, the heart and pericardium. Mild cases may improve on their own. Treatment for more severe cases may include medications and rarely surgery, but early diagnosis and treatment may help to reduce the risk of long-term complications. Acute pericarditis usually lasts less than a few weeks. The most common symptom is that sharp, stabbing chest pain behind the breastbone or in the left side of the chest. Some people with acute pericarditis describe their chest pain as dull, achy, or pressure-like instead, and vary in intensity. Pain of acute pericarditis may travel to the left shoulder and neck. It often intensifies when lying down or inhaling deeply. Coughing, taking a deep breath, or swallowing food also may make the pain worse. Sitting up and leaning forward can often ease the pain. At times, it may be difficult to distinguish pericardial pain from the pain that occurs with an MI. Chronic pericarditis lasts 6 months or longer and is usually associated with an accumulation of excess fluid around the heart, the pericardial effusion. Often painless, the most common symptom of chronic pericarditis is shortness of breath. Pericardial effusion defines the presence of an abnormal amount or character of fluid in the pericardial space. It is an accumulation of excess fluid around the heart. Echocardiograms are useful in detecting the presence of a pericardial effusions associated with pericarditis. Anti-inflammatory medications are used if there is no treatment threat of tamponade. So aspirins, nonsteroidal anti-inflammatory drugs such as indomethacin or ibuprofen can be given. If the patient does not respond to medications, then a corticosteroid such as prednisone may be given. Invasive procedures. If an anti-inflammatory treatments do not correct the problem, and if the patient has a tamponade or at risk for a tamponade, they will most likely want to drain the fluids or prevent fluids from accumulating again. A pericardiocentesis is where they would take a catheter and drain fluid from the pericardium. An imaging device is used, either an echocardiography or an X-ray technology called a fluoroscopy, to guide the direction of the catheter. The heart is monitored during the procedure with an ECG machine, and in most cases the catheter will be left in place to drain the pericardial space for a few days to prevent reaccumulation of fluid. Open heart surgery would be needed if there's bleeding in the pericardium. Intrapericardial sclerosis is a procedure where a solution is injected into the space between the two layers of the pericardium that essentially seal the layers together. This procedure is usually used if they have a recurring pericardial effusion or if the effusion is caused by cancer. Pericardectomy is a surgical removal of all or a portion of the pericardium. It is rarely performed and is usually reserved for treatment of recurrent pericardial effusion despite catheter drainage. Cardiac tamponade is when too much fluid collects in the pericardium. Excess fluid puts pressure on the heart and does not allow it to fill properly. This means that less blood leaves the heart, which causes a dramatic drop in blood pressure, and if left untreated, cardiac tamponade can be fatal. The difference between pericarditis and cardiac tamponade is that pericarditis is one cause of fluid accumulation in the potential space. Cardiac tamponade is a hemodynamic result of the fluid accumulation. When cardiac tamponade occurs, it is considered a medical emergency, and pericardiocentesis is performed to remove the fluid or blood that has collected around the heart and is preventing the heart from pumping effectively. Oxygen rest antibiotics and antidysrhythmic medications may be indicated after the pericardiocentesis is performed. Following a pericardiocentesis, a rise in blood pressure and fall in central venous pressure are expected. The patient usually expresses immediate relief and the heart sounds are no longer muffled or distant. For nursing management, keep in mind that the first 6 hours after the onset of pain is a crucial time frame for salvage of the myocardium. Pain control is a priority, usually with IV morphine. Continued pain is a symptom of myocardial ischemia. Pain also stimulates the autonomic nervous system and preload, increasing myocardial demands. Nursing recommendations are to elevate the head of the bed and begin oxygen therapy. Immediately report patient complaints of chest pain and shortness of breath, anxiety, or sense of impending doom. The signs and symptoms of pulmonary embolism are similar to those of a myocardial infarction. Prompt intervention to restore pulmonary blood flow can reduce the risk of significant adverse effects. Hypertensive crisis is a severe increase in blood pressure that can lead to a stroke. Sudden withdrawal of antihypertensive medications can cause rebound hypertension and hypertensive crisis. It is essential to avoid excessive falls in blood pressure, which can precipitate cerebral, renal, or coronary ischemia. A hypertensive crisis is divided into two categories, urgent and emergent. An urgent hypertensive crisis is when the blood pressure is extremely high, but they don't suspect any damage to the organs. Signs and symptoms of urgent hypertensive crisis may include increased blood pressure, severe headache, severe anxiety, and shortness of breath. An emergent hypertensive crisis is when the blood pressure is extremely high and is now damage to the organs, and this is causing life-threatening complications such as pulmonary emboli, cerebral edema, aortic dissection, heart attack, stroke, and high blood pressure with seizures, eclampsia, if the patient is pregnant. An aortic dissection occurs in the weakened area of the aortic wall. Chronic high blood pressure may stress the aortic tissue, making it more susceptible to tearing. It can also be an inherited condition, known as Marfan syndrome. Aortic dissections are divided into two groups depending on which part of the aorta is affected. Type A. This is the most common and dangerous type of aortic dissection. It involves a tearing in the ascending portion of the aorta, just where it exits the heart, or a tear extending from the ascending portion down to the descending portion of the aorta, which may extend into the abdomen. Type B. This type involves a tear in the descending aorta only, which may also extend into the abdomen. Visible pulsations of an abdominal aorta is commonly observed in the epigastric area for thin individuals. Both thrills and murmurs are caused by turbulent blood flow, such as occurs when blood flows through a damaged valve. Remember, you feel a thrill, you hear a bruit. When an aneurysm is expanding or preparing to rupture, the patient may experience severe sudden back or lower abdominal pain that can radiate to the groin, buttocks, or legs. Graft occlusion or rupture is a postoperative complication following abdominal aortic aneurysm repair. The nurse should monitor the patient for increase in abdominal girth, cool or cold extremities, white or blue color in the flanks, and severe pain. Elevating the head of the bed would place too much pressure on a surgical site. A ruptured abdominal aortic aneurysm presents with a triad of symptoms, including abdominal pain combined with intense back and flank pain and possible scrotal pain, pulsating abdominal mass or a rigid abdomen from the hemorrhage, and shock. Surgery is the only intervention for patients with a ruptured abdominal aortic aneurysm.